Good afternoon, everyone, and thank you once more for taking the time to join us this afternoon for our final webinar of the year. My name is Shanti Singh Anthony, the Knowledge Coordinator of PANCAP, based at the PANCAP's Coordinating Unit in Georgetown, and I will be your moderator for the session today. Let me extend a warm welcome to you on behalf of PANCAP and the Director, Mr. Derek Springer, and thanks again for joining us. The region has committed to achieving the 90-90-90 by 2020 and ending AIDS by 2030. And in this regard, the series of webinars organized by PANCAP is aimed at facilitating the discussion on the scientific evidence and sharing implementation experiences around these targets. Before we begin, a few logistic and operational points to note. Firstly, your mics are muted. If you have questions as the presentation progresses, please type these in the question bar on your panel. We will address them during the question and answer segment at the end of the webinar. Secondly, in relation to the flow, we'll take the presentation and this will be followed by the question and answer segment. Again, please type your questions in. Finally, the webinar will be recorded and shared on PANCAP's website for the benefit of the wider partnership. According to UNAIDS 2016 update in June of this year, the Caribbean has achieved a viral suppression rate of 67% among all persons living with HIV and receiving antiretroviral therapy. Delving a little deeper, this translates to 34% of all people living with HIV. Furthermore, UNAIDS has established that to achieve the third 90, the region has to put an additional 120,000 persons living with HIV to achieve viral suppression. The task ahead, therefore, is significant. This afternoon, we're privileged to have presenting to us Ms. Valerie Wilson on the third 90 of viral suppression. Ms. Valerie Wilson has been the director of the Caribbean Med Lab Foundation since 2008. The Labs Foundation is to promote and support the achievement of quality laboratory services in accordance with appropriate standards through advocacy, resource mobilization, collaboration, research, and education. Valerie holds a master's degree in immunology and a master's degree in business administration, and has had extensive training and experience as a public health professional. Ms. Wilson previously served as the Caribbean Epidemiology Center, at the Caribbean Epidemiology Center, as the laboratory manager. One of the main focal areas of Ms. Wilson at the Caribbean Med Lab Foundation in the past 9 years is on strengthening of laboratories to support HIV-related services within the Caribbean. It is therefore my pleasure to hand over to Ms. Valerie Wilson, to make her presentation to us on the third 90 of viral suppression. Over to you, Valerie.
Thank you very much, Shanti, and I hope you're all hearing me clearly. It's a pleasure for me to be here this afternoon to do this webinar, and I would like to thank Shanti and PANCAP for giving me the opportunity to share some of the experiences and information about what is happening within the region with respect to the third 90. So I'm going to focus this evening on I was trying to, my slides are not moving, I wonder why. Sorry, my slides were moving earlier. Not sure why they are not moving now. Let's see. Just give me 1 minute, let me try again.
Valerie, instead of using the your browser clicker, you can use the keyboard, the tabs on your keyboard, to go back and forth.
That's what I was using actually, and that's okay. It just suddenly started up. I just went out and came back in.
Oh, there you
Okay,
go.
sorry about that. Okay, so actually to outline what I'm going to cover in this presentation, thanks for your patience with that. I'm going to look at basically the background in terms of the critical importance of viral load monitoring, the options that are available for viral load monitoring, taking a very laboratory, of course, focused approach to this topic, and looking at laboratory networks in terms of the successes and challenges we've had with respect to viral load, and what are some of the considerations for sustainability. So we know we've been looking at the third 90, and we are looking at the third 90 today, but as we think about 90, 90% of all the persons living with HIV know their status. This really relies on HIV testing and reaching all the populations, including key populations of persons who may be infected with HIV. The second 90, all the 90% of those who are positive would be on antiretroviral therapy. And this again requires CD4 testing and viral load testing. And finally, the third 90, looking at the percentage of persons who are virally suppressed. So we really have at every stage of the 90-90-90 need for laboratory services. And when we look at the EMTCT, elimination of mother-to-child transmission, which is a major focus for the Caribbean at this point in time, also requires access to testing services. So testing services really underpin the achievement of these 90-90-90 targets. So when we look at, and this is just an example of the kind of cascade, and I'm sure that most of you who are present on the webinar have seen these treatment cascades in the past, but just to highlight that as we look at treatment cascades, it's really important to be looking at what's actually happening for key populations within those cascades, because we have national cascades, but looking at what is happening with key populations is also important. This is just an example from COIN in the Dominican Republic, where they have actually shared what they are seeing with respect to HIV cascades among key populations. The general population, the first group, the female sex workers, where you can see that actually the third 90 is actually better than among the general population. The MSM, where it's almost equivalent, and the drug users, where you're seeing the fall off actually is in those who are retained in care in some of these cascades. And certainly among trans and migrants, you see a real fall off in terms of that final 90. So it's really important, I think, looking at this, it really sends us a message about how critical it is to ensure that we are looking at that, at the 90-90-90, not just from the point of view of the overall population on the left here, but the varying kinds of pictures that we see among other groups. So when we talk about viral load and HIV transmission, we can go back as far as 1998, actually. The discussion began about the association of HIV transmission with levels of HIV RNA, the source of the virus, in blood and the genital tract. And later publications really endorsed this until 2011, when, you know, I think it was basically accepted that viral load is really a key factor in the issue of how transmission is actually promoted with respect to HIV in the blood and genital tract secretions. So why is viral load monitoring important? It is certainly important for identifying acute HIV infection, because persons with the acute infection are going to have increased viral load. It is important at the start of treatment, and I know that several countries are not yet doing viral load at start of treatment, but it is really a critical parameter at that point, so that we can see what is actually happening with patients who are placed on treatment and how their viral load varies. It's important for monitoring the effectiveness and efficiency of the antiretroviral treatment. So as in most cases, lab tests are necessary for diagnostic and then for monitoring. We need it for early infant diagnosis and also for, of course, monitoring viral load suppression which is what we want to do when we meet the third 90. What do we mean by when we say viral suppression? And I know many of you are very well acquainted with this, but for the persons who may be less well acquainted, viral suppression really occurs when antiretroviral therapy reduces a person's viral load to an undetectable level. It doesn't mean that the person no longer has HIV. It's not a cure. HIV still remains in the body. And if the antiretroviral therapy is discontinued, or if, for some reason, persons do not take their medication, viral load will likely return to a detectable level. And if you look at the diagram, it really shows the viral suppression, the viral load before we put persons on ART, and then viral load with ART, still showing in the slide that you still have a very small amount of virus present, even though it may not be detectable by the tests that we have. And that's the point, that the tests that we have may not be able to detect it, but it is still very much present. So let's look, and it's really important to remember, and I think this is something that came up very strongly at the recent CCAS meeting, that undetectable equal uninfectious. U is equal to U. And that's a really important statement for us all to remember. This is what we really want to achieve with all persons who are HIV infected, so that in fact they, by suppressing their viral load, they become uninfectious. So WHO in their 2017 publication indicated that viral load is recommended as the preferred monitoring approach to diagnose and confirm treatment failure. And basically their message was that if viral load testing is not routinely available, then CD4 counts and clinical monitoring should be used to diagnose treatment failure, with targeted viral load testing to confirm viral load failure where possible. So viral load really is the key thing to determine whether we are seeing treatment failure or treatment success. And in settings where routine viral load monitoring is available, in fact, CD4 cell count monitoring can be stopped in individuals who are stable on ART. And this is WHO's recommendation as of 2017. But it means that routine viral load monitoring must be available on an ongoing basis. It's also really important for us to think about treatment as prevention and the role of viral load in treatment as prevention. It is more informative than CD4, and this was actually published by Davy Smith and Robert Shuley. And in 2008, they actually published a paper called Running with Scissors, using antiretroviral therapy without monitoring viral load. And basically, they were making the point that if a choice has to be made between viral load or CD4 cell counting, then it would be more useful to monitor viral load. And the final statement that they made, failing to use laboratory tools that monitor treatment success is like running with scissors. It is all quick and easy until someone falls down. And really, I think this really sends us a very strong message about how important it is to have monitoring for viral load in all cases where persons are on antiretroviral therapy. So how do we monitor viral load? Well, there are many different ways of doing that. They all depend on different kinds of equipment, availability at different points. You have viral load testing in the large volume in lab analyzers. And these are just some examples of the kinds of large analyzers. A lot of the analyzers that are used at the larger labs in the Caribbean, Jamaica, Trinidad, Guyana, in the, of course, larger countries like Haiti and the Dominican Republic, they rely on the very large analyzers to do the viral load. And so you get those analyzers from Roche and Abbott and so on. And then you have the options for smaller environments, the point of care viral load and early infant diagnosis products. Some of them are available already, some are in the pipeline. You have things like GeneXpert, which is one of the ones that is fairly well known within the Caribbean. You have AlaiQ, which is another fairly well-known one. You have the Samba, and a number of others, Liat and so on. The point about these, and the really important point, is that they are actually able to detect viral load to be used in environments where you do not need as much training. And let's look at what are some of the examples of what has actually happened with viral load suppression within the region. And then we get back to talking a little bit more about the options for the technology. So with respect to viral load suppression, we've had studies done by Professor Landis et al. In Barbados, looking at 7 countries, the OECS countries, and they tested greater than 3,500 samples in 5 years, and they published this in 2015. And they were able to show significant viral load suppression within the OECS as a result of the network established to provide reference services. So their point was that viral load was a useful M&E tool for HIV/AIDS programs, and it actually enabled the programs through the monitoring to really reduce viral load over time. And this was a really important finding. In terms of Barbados, because this work was done by Professor Landis and others at the Lady Mead Reference Laboratory and Unit in Barbados, they also published on community HIV viral load in Barbados between 2002 and 2011. And if we look at the results for patients on ART, who the percentage of persons suppressed went from 58% to 76% from 2002 to 2011. So the increase in suppression was clearly major. And if we look at the percentage with high viremia, it actually reduced significantly over time. And if we look at the patients who were not on ART, you can see that the percent who were actually suppressed was much less, 7.3% going to 48%, as compared to 76% of those who were on ART. And as a result, the percentage with higher viremia was also higher because they were not on ART. So this was experienced in the Caribbean with respect to monitoring what is happening in the community with respect to viral load in Barbados. So with respect to the question, is treatment prevention, the 10-year trend really showed an improvement in viral load suppression between 2002 to 2011, from 33.6% of clients achieving the 200 copies per ml threshold, and that's what we call viral suppression, in 2002 to 70.3% in 2011. Then estimated 26.2% viral suppression at a population level at the end of 2010. And that compares very well with the US figures in the MMWR in 2011, which was at 28%. So this really was significant work actually being done here in the Caribbean at the Lady Mead Reference Lab, and showing how monitoring of viral load could actually influence the suppression levels at a population level over time. But what about some of the countries that actually depend on the service to be provided through labs that are actually experiencing great financial challenges? And we are seeing this more and more throughout the region. And this is just one example from a country that has had interrupted testing over the period 2013 and 2014. So as we look here, we can see CD4 testing interrupted both in 2013 and 2014. And this is interrupted not for a week or two we're talking about here. We're talking about sometimes as long as 6 months to a year. We're seeing basic tests like CBC, complete blood count, which is uninterrupted, which is fine. Viral load, uninterrupted in 2013, but interrupted in 2014 when donor funding actually came to an end. Simple things like GC, gonorrhea testing, interrupted. Liver function tests, which are also important for monitoring patients who are on treatment, interrupted in this environment. So what we're seeing is patterns of testing that are interrupted for significant periods of time. As I said, I'm not talking about a week or two, we're talking about months, several months, 6 months to a year, sometimes longer than that. And this is just one example. This has been happening within the region in several of our countries. So this sends a message, because remember we said that viral load monitoring is critical and has to be done on an ongoing basis, at least with respect to the requirements, the guidelines, which state generally in the Caribbean that we should have at least 1 and most likely 2 viral loads per year. So if we are interrupting the testing for periods of 6 months to a year, you understand that this means that sometimes people are not getting their viral loads done as should be. So when we look at centralized viral load testing, we can see that there are some advantages, significant advantages. So we're going back to looking at, okay, what's the technology that's available? The technology for doing centralized viral load testing allows you to get very accurate results, very reproducible results. You can have a reference lab, and we have a number of our reference labs in the Caribbean have now been accredited. The Barbados Lady Mead Reference Lab, the reference lab for HIV in the Bahamas, and some of the other labs, the lab in Curacao. We have a number of labs that have actually been accredited. So the lab quality management system at the reference lab may be a very strong system, and therefore you can get very highly accurate and reproducible results. Cost reductions are also possible because of volume, and that's another big advantage of using these kinds of major equipment at the reference lab. And then of course you have the staff skill at the reference lab on which you can depend for getting those very accurate and reliable results. What are some of the disadvantages? The disadvantages are the extended turnaround time, because it means that samples have to come into a central point, be tested, and then results have to go back out. And depending on what the situation is, and I'm going to get into exploring some of those issues in a short while, the turnaround time can be quite extensive. The transport of samples also adds time to the challenge. You can get missing or delayed results, the results that never arrive. We've seen results that get produced at the reference lab, and 2 months later, they're still to arrive at the point where they need to be used for patient care. 2 months later, is the result really a useful result for a clinician who's trying to decide if a patient is well controlled on the antiretroviral medication that they're taking? The systems and processes for receipt of results often not really very tightly controlled. You have to maintain the cold chain in terms of the submission of samples, because viral load is very susceptible to temperature. You need and you have to use very delicate instruments within the reference lab, and the staff skill level is significant, and you must have significant access to equipment maintenance. So this is if you centralize viral load testing. If you don't centralize and you use one of the point of care options, there are some advantages, some significant advantages, and you also have some disadvantages. You have advantages that they're easier to use, so you need less skill. But the big point about it is that with some of those point of care devices, you can actually do other kinds of testing. So you can do on the same equipment that you do HIV, you might be able to do TB, you might be able to do influenza, and so on, because those equipment really use cartridges, but you have to purchase the different kinds of cartridges for the different kinds of testing that you want. Of course, cost and sustainability is a major issue in those point of care devices for countries that are already having limitations to provide simple basic tests like liver function. So we really have to consider how critical is viral load testing, and how can we ensure that the kinds of methodologies that we put in place can in fact be sustained. So this is an example of a study that was done in collaboration with PAHO and one of the countries in the region. And the Ministry of Health was interested in increasing viral load monitoring capacity in a sustainable manner to achieve its 90-90-90 targets and move to test and treat. And they wanted to reduce viral load test turnaround times, because this was clearly seen as being a major challenge, and to improve HIV treatment outcomes as a result, and to increase 40% of persons who are HIV positive on treatment, currently at the time they were working with 30%. This was a study that was done just recently in the last year. So the preliminary MOH assumptions were that viral load costs would, lower viral load costs would result in higher sustainability, that deployment of point-of-care equipment, because they were looking at point-of-care equipment to put into their regional labs to increase the national treatment monitoring capacity, and that decentralization would improve turnaround time and also improve treatment outcomes. So these would be the kinds of things that generally a Ministry of Health would think in terms of introducing point-of-care. And this, of course, these were the assumptions that the Ministry was utilizing in terms of looking at what might be the outcome in terms of introducing point-of-care. So there were some key factors that were considered as part of the team that went in to look at these options and to give the Ministry some advice on behalf of PAHO. And we looked at demand and access. We looked at testing capacity, the technology, what technologies would allow what kinds of capacity. We looked at things like policies and practices, the infrastructure, the organization of the lab workflow, the manpower and competence, the data management and reporting systems, the transport and sample management, logistics, the timeliness of results for clinical use. And we clearly found that timeliness of results was clearly a major problem. Looking at delays in results that were 2 months and sometimes even much longer than that. There was significant procurement logistics in terms of ensuring sustainability of the centralized testing. And of course, the whole issue of quality coordination, standards and compliance. And how would this testing actually be sustained? How would the costs actually vary if, in fact, point-of-care testing were to be introduced? So it was really a very comprehensive assessment of the factors that impact on viral load monitoring in that particular environment. Basically, the assessment outcomes were that centralizing the testing at the National Reference Lab had the potential for much more attractive pricing of tests, because by centralizing, they were able to look at volume discounts. And that actually was one of the very important factors in all of this. The challenges with respect to turnaround time for delivery of results to the clinics were the result of internal and external issues. Internal issues related to workflow, staffing, the infrastructure, and the data management, because the lab, the reference lab, was functioning with its own lab information system, but the lab information system was not actually delivering results to the clinic sites. So the external issues were things like transport and the receipt of results from the reference labs to the clinics. So these were major issues that were impacting on turnaround time. The second option that was looked at was decentralizing to include one additional site. So the first one was centralizing, the second one was decentralizing to include one additional site, which could increase the timeliness of results while retaining the potential for attractive pricing. There were challenges of infrastructure at the second site and allocation of staff. And again, the whole issue of lab information management was a major issue, because we were still looking at really decentralizing, but only to one additional site. And the third option looked at was the implementation of point-of-care instruments, which had the best potential for increased timeliness and alignment with clinic schedules, increased testing, and improved timeliness of care and retention in care. The challenges there, actually, as it turned out, were infrastructure, biosafety, workflow, among other concerns at those sites. The introduction of point-of-care testing actually potentially had an impact, or could have had an impact, and it actually would have had an impact on the pricing of the reference lab testing because of reductions in volume. So it would have significantly reduced the reference lab testing, and therefore it would have impacted very negatively on the pricing. But the major challenge really was the infrastructure, biosafety, and workflow at these sites, which really did not facilitate the opportunity for introducing additional testing at those sites without addressing those particular issues. So the solution that was found was to maintain the central reference lab testing with a possible expansion to one additional site, and to implement a laboratory information system linking the clinic sites with the lab. So this would actually reduce a lot of the time that was taken after the lab result was produced by the laboratory. The need to improve the transport systems was also identified, and to improve the quality management system, including the monitoring of turnaround time, because it was really important to use turnaround time as an indicator for monitoring what actually should be happening with respect, and what was happening with respect to the return of results from the reference lab to the clinic sites. So there are clearly some major improvements needed to laboratory services in order to meet those 90-90-90 targets. We need, of course, on the front end to ensure access to quality HIV diagnostic testing, but we also need to improve the access to the monitoring services that are required for persons who are already on treatment or persons who are awaiting being put on treatment, because their CD4 and viral load also needs to be monitored. The community linkage, of course, is required, and that is the subject of, I think, another webinar, to ensure that the quality of service provision and retention in care is achieved. And that's really, really an important aspect of this, because it's all well and good for us to say put people on treatment, but if we don't have good linkage to ensure that persons are retained in care, then in fact we have the worst possible outcome, which is people start treatment and then stop. And that has, as we all know, major implications for resistance and so forth. We need cabinets to adopt and implement their national lab policies. Why? The policies are actually policies that ensure quality monitoring, access to testing services, the coordination that's necessary at a national level, and the monitoring for overseeing all of this. Viral load, like any other test being done in the lab, requires quality management systems, and these policies are really intended to ensure that all labs, including those labs, remember the study that I just reported to you, where in fact there were sites where in fact it would have been reasonable to say, let us put point of care testing devices at these sites, but the sites themselves were not meeting standards sufficiently to be able to be considered for that purpose. We need dedicated budgets to ensure sustainability of lab services in light of changing donor priorities. Without dedicated budgets, things like viral load and CD4s are going to be things that immediately feel the impact, because they are much more expensive tests than some of the routine chemistries and hematologies, which are always seen as priority within clinical environments where you're serving a hospital that, where NCDs are the major issue. So I think we really do need to look at the issue of how we are ensuring that lab budgets are sustained. And we need to also negotiate better pricing. And that is something that is already underway with the OECS. We are working with OECS Pharmaceutical Procurement Services to look at that for the OECS, but it is also being expanded beyond the OECS to other countries within the region to try to ensure that negotiated prices are available through the PAHO Strategic Fund or through other means. PAHO Strategic Fund has certainly embraced the whole issue of viral load and viral load testing. But there are many other lab supplies that really need to be included and to be negotiated to ensure that labs are able to sustain their testing. We need, of course, to improve our procurement and maintenance services, because even as we talk about sustaining budgets and negotiating better pricing, the whole process of procurement in most of the labs in our region, which depend on the national procurement systems, are really quite deficient and result in many instances in stockouts, that should be avoidable if, in fact, the procurement processes were actually as efficient as they should be. And of course, the maintenance services. Maintenance services are really critical for all kinds of equipment. Most of our analyzers now, including the viral load, the equipment that does viral load testing, most of those analyzers really require manufacturer maintenance services because they are highly complex pieces of equipment. So we really need to make sure that, you know, our lab equipment is covered by the kinds of maintenance contracts that are necessary. Just as we have to cover our theaters and our you know, MRI facilities and so on, we need to do the same for the lab equipment that actually provides the decisions about how treatment should be continued, stopped, changed as necessary to ensure that we meet that third 90. So I will stop at this point. I think one of the questions, or we had some questions that we wanted to ask, and really to get a sense of, is viral load testing consistently available in your country? Are viral load results available in a timely manner, and are there any challenges with viral load testing? Just to get a sense of what's happening within the region with respect to viral load. We have some ideas about what's happening in some countries, but we wanted to open the question up to everyone. So I thank you all, and I'll turn over now to Shanti to continue.
Yeah, thank you so much, Valerie. The questions will go out to the participants at the end of the webinar, so please look out for these. We have a few questions, Valerie, and I'll probably ask them one at a time. So the first question is on the slide that you had with the continuum of care for CVC COVID. And I think the observation is made that there is really a striking difference between persons who are retained on ARVs and those who had and among those persons who have had a viral load test. And so while we speak to viral suppression, I think that really speaks to access to viral load testing. And so while this is just CVC, I'm wondering if you can share a little bit more in terms of what's going on in the region. So you can see, for example, that the difference in the general population, the difference between the green and I think that's a purple, between those two bars is really very different. So you have 60% of people on ART, but you only have viral load results available for less than 4%, let's say 35% of the persons. And a similar picture is seen across the different populations. So in my mind, it speaks not just to viral suppression, because for us to achieve viral suppression, you have to have a viral load test. So I just wanted to know what's this is CVC COVID, but what's the situation like in the region?
Yeah. So good question, Shanti, and I think this is actually at the crux of the discussion surrounding this particular session, because in fact, one of the things that we see very frequently, and a lot of the data has shown, that in fact viral load is not actually being done as really required for persons who are on ART, and that frequently happens. Why does this happen? Well, there are several reasons for this. In many cases, as happens in the DR, for example, when viral load, and that's why I included that study on the centralization issue for viral load. Because when viral load is actually centralized, the issues are not so much about whether the test can be done, but whether the reagents are available in the major reference lab, the transport arrangements for getting those samples into the lab, the return of samples from that lab in terms of whether they get lost, whether the results get lost, etc. So some of those kinds of very basic things are the things that sometimes people don't really think about with respect to labs, but labs are places where all the logistical arrangements are really, really critical to ensure that the service can be provided. So where you have a large country like the Dominican Republic, one of the things that they are actually looking at is also the whole issue of decentralization and how they could best decentralize. As I indicated in the example that we used and that we were involved with recently, the issue of ensuring that you have good communication of the result back to the provider is really, really a key part of that. If you have a centralized system, then the transport and the return of the transport of the samples, maintaining the cold chain, ensuring the timeliness of the sample transport, and then the return of the result back to the clinics really makes a tremendous difference. If you're not able to do that and to assure that, of course, at the front end, the samples must be taken in the first place. And we have seen situations as well where sometimes people's viral loads just not requested. Why is it not requested? Sometimes the clinician may not request. Sometimes the clinician may be of the view that the lab does not have the necessary reagents, etc. in place. Many times there are major gaps in provision of service because of equipment and reagent being stockouts or equipment being down. And we know this happens in several countries and has happened in several countries in the region. This is an ongoing problem. Labs really require a lot of logistics. That is really, a very important message for us all to understand. So procurement and maintenance services are really fundamental to providing a service. So all of those things really impact on this serious decline that you see between those who are on ERT and those who have viral load form. So you see a huge downturn with MSM, and I think one of the things is how you actually retain persons so that they will come back in for the viral loads as necessary. And you could see that you have a great variation here with the migrants, for example, and the MSM, because in fact there are obviously persons who are on treatment who may not be actually staying in touch with the treatment site. So you also see that as one of the problems in terms of ensuring that people are getting the necessary viral loads. So it's really a complex, of many different things that impacts on this overall.
Thank you, Valerie. A follow-up question on the turnaround time. And I noticed that from one of the slides that one of the external issues in terms of getting results is actually the delayed turnaround time, being able to issue the receipts. But I think that the context will vary, and I'm going to use that as an example, because if you have to have a receipt sent, for example, from Georgetown to the hinterland region, then you have to fly that into the plane and so forth. And what was done in this specific instance is that you can either call up the site, speak with a physician, and transmit that report verbally. But a lot of us now use cell phones, and we take pictures and photographs of those results, and we send them via WhatsApp, we scan and we send, and so forth. And so my question to you, how acceptable is that? I know that laboratory science is really very specific, but there has to be some connection between the laboratory and the clinician who is waiting on the other end for the result. And I know these are discussions that have been ongoing in terms of what do you really use to be able to make the judgment for your patient?
Yeah. Well, I think, it's one of the things that is, of course, as you know, the requirements for labs, the standard for labs actually prescribes certain things in terms of delivery of results, etc. It is permissible to call a report in, but in fact, in doing so, you have to have a very specific way of doing that. So, you have to call, you have to make sure you know whom you are transmitting the result to, you have to document who received the result on the other end, you have to make sure they repeat the result. So there's a whole process that has to be included to ensure that you don't get the wrong result communicated. Because that is really the concern, that you get the wrong result for a particular patient. WhatsApping the result is something that I think people are doing, and it's a creative use of the technology. in that particular case, you're actually taking a photo of the actual result and transmitting it. So once we're not having any interference in the system, then in fact it should actually be reasonable to do so, especially in situations where you have a hinterland region where you can't get results back in a hurry. But the issue of telephone results is really a very prescribed one within the standard for labs.
Thank you, Valerie. That's really good. There's a question on point of care testing. So the first question actually on point of care testing is we've seen the good progress based on the timeline that you showed on one of your slides, the good progress that has been made in point of care technology and development of point of care technology. What I wanted to know is all of those that you have on your slide, one, whether they're FDA approved, and two, do we have any experience with the use of viral load point of care technology in the region? And I ask this specifically because my limited understanding of point of care testing is that it also is dependent on volume if you're to use that cartridge. And considering our context, where in many countries we have small HIV populations, relatively small HIV populations, how much of that is understood in terms of the use of point of care testing?
Yeah. So in fact, the first part of your question related to FDA approvals, and actually a lot of these, in fact, some of these are also WHO approved. They're actually on the WHO approval. The WHO had not actually approved any of these point of care instruments until last year they began. So I think, there are a few of them that have begun the process, but, it's still very early days in terms of approvals for point of care, use of point of care instruments for viral load. Having said that, something like the Gene Expert, for example, is one of those technologies that is actually approved and actually supported by the Global Fund. And Gene Expert has been expanding the list of available tests to include a very wide range of bacterial and viral agents. Having said that, the issue of volume comes in, because when you have a small lab, then your volume is quite small, and to be able to support a point of care instrument, even though they are not as high volume as those large analyzers, you still do need to have a minimum volume. And that's where our challenge comes in small countries where you have very small populations of HIV-infected persons. And it's one of the reasons why I think it's going to become important for us to really negotiate jointly for the pricing of these items, because if an individual country has to negotiate on its own, then in fact it's going to make the price of these things, really not sustainable in the long run.
Okay. Thank you, Valerie. This is from me, not a question, but maybe a comment and a question in the comment. But I noticed your slide on before viral load, liver function test, and so forth, 2013-2014 comparison. And I still wonder, even though I know the difficulties, I still wonder how do you move from a place in 2013 of having uninterrupted viral load reagents to 2014 having that interrupted. And like I said, it may not be a question, it may be a comment and a question at the same time. Yeah.
Well, I can tell you, I think I mentioned actually while I was talking about this, that in fact, in many cases, the viral load in particular had to do with donor funding that actually ended during the 2014, going into 2014, where donor funds were no longer available to pay for the viral loads, and so there was an interruption in service. You also see, for example, that CD4s were interrupted from 2013 into 2014, and even something as simple as liver function tests. So this is a country where the financial situation changed drastically. A lab which had never experienced this kind of stock-out situation in years gone by, but has really been undergoing a lot of challenge with respect to this over the last few years because of the financial situation and the changes that have taken place in the finances.
Yeah. One final question from Ian Valerie, and this is out of curiosity because I've seen programs where the rejection rates for viral load testing has been really very high. What would you say is the acceptable rejection rate, and would that vary from context to context?
It would, but usually the way in which labs normally would function is that they would set what they would expect to be a rejection rate. So generally, what labs try to do is to set that as it's really an indicator that they should monitor. So if the lab actually sets an indicator that 80% of the viral loads that are submitted should be able to be processed at the lab without any problem, then in fact when it falls below that, it's really more about how does the lab introduce a process to address those things. Because in fact, even those samples are coming from outside the lab, and often, many times people in labs feel, oh, it's not my responsibility to deal with that, they have to get the sample here. In reality, it's about how does the lab work with the clients that are using the lab service and the clinicians and the persons who are actually taking the samples and transporting the samples to ensure that in fact the samples reach on time, that the cold chain, because this is one of the issues of viral load, and that's why transport of viral load samples is such a major issue, because the time and the volume and also the temperature are really, really critical aspects in the transport of these samples. So that's where, in fact, the lab really needs to set itself a target, and those targets will vary and may vary by context. For example, if you're in the hinterland versus if you're, in a city environment. But the lab sets those and then must investigate as part of their quality system. The lab should actually be tracking those receipts and then determining from an analysis of their data whether in fact they need to investigate and try to remedy a situation that may have arisen. So the lab is really reaching well outside of its walls to, should be reaching well outside of its walls to ensure that samples are able to be received in a manner in which it facilitates the testing that needs to be done. And it can be quite complicated because when you are talking about something like viral load, for example, the OECS countries rely on Barbados for viral load testing. And so the viral load testing that has to be done in Barbados is reliant on air transport, on transport within the country, and then the transport within across the seas. So again, it means that tracking what is happening is really important, because if particular countries are having particular issues, then they need to be addressed in terms of the referral, or particular environments are having problems, then those problems need to be addressed and resolved to ensure that you're not wasting a lot of resources trying to get samples in, and then the samples are actually no good and not benefiting the patients and the clinicians in any way.
Thank you so much, Valerie. That was great. There are no more questions at this point, and so this really brings us to the end of today's webinar. A few reminders: you will receive the presentation shortly. You will also receive very shortly a questionnaire seeking your feedback on the webinar. Your feedback is really important for us. It will allow us to better understand and therefore address the knowledge needs of our audiences. And so on behalf of PANCAP, the Director of PANCAP, Mr. Derek Spring, on the participants today, Valerie, let me thank you again for investing in the webinar and sharing such rich experience with us this afternoon. To all of the attendees, thank you so much for joining us today, and we trust that you would have learned something on the third 90 and on viral load. As a reminder, the webinar will be recorded. The webinar was recorded and will be posted on PANCAP's website for the benefit of the wider partnership. And like I said earlier when I started the webinar, this is the final webinar for the year. And so on behalf of Mr. Springer and the entire partnership, I would like to thank all of our presenters who would have contributed in making this series a success. We wish you and your families a very Merry Christmas and a prosperous New Year. This is early, but we have to do this. 2018 promises to be another exciting year for the partnership, so do continue to stay engaged with us. For more information on the HIV response, please visit the PANCAP's website and follow us on our social media platforms, Facebook and Twitter. Thanks again, everyone, and have a great day.
Thank you, Shanti. Thank you, everyone.
Thanks, Valerie.
Bye. Bye.